Hello, Dr. Blaisdell. How are
Hi,
you?
Sherry. How are you? Good, thanks.
Good. Everybody, I just want you to know I call him Doc Chris, but he is Dr. Blaisdell. Doc Chris, tell me why we would use PRP with leukocyte-poor or leukocyte-rich. Tell me the difference.
That's a great question. So PRP, just as refreshing the memory. So PRP is basically when we take your own blood and we spin it down and we capture the part of the blood that's used for regeneration. Now, this part would be can be injected into places that have poor vascular supply under ultrasound guidance, so it's very specific. And the advantage with this is your body's not able to produce and deliver this much regenerative material. So we're able to do it under ultrasound guidance. Now, so the PRP can have a lot of white blood cells or leukocytes, or it can have few white blood cells or leukocytes. And the advantage with the leukocyte rich PRP is that it's a little bit more regenerative. The reason being is because the white blood cells is actually what institutes or is part of the cascade of healing. The problem with it, however, is that it requires inflammation to work. And so the white blood cells produce inflammation, which produces healing, and it's part of the healing cascade. The problem
So,
with that
l-
is
I'm sorry to cut you off.
that's right.
I have a quick question. Can you explain to me why some PRPs inflame my knee versus why others did not?
Right. And this it goes exactly to your question, which is what's the difference between leukocyte rich and leukocyte poor? The probable cause for this is that they have leukocyte rich platelet PRP that they injected into your knee. As I was mentioning, the leukocytes are part of the inflammatory cascade, which is part of the healing process. That does, however, create pain because inflammation and swelling equals pain. So, what we do is sometimes we create a fraction of that PRP that has fewer leukocytes in it. And that has molecules that do other things that do promote healing, but they're actually more inflammatory. So, you could kind of look at it as like cooling off a joint or reducing the inflammation. And the advantage of this is it kind of sets the stage, kind of like makes the environment more fertile, more receptive to more regenerative stuff that we could do in the future. That is that's more inflammatory.
So, like now that we have a new protocol here, okay, for knees, where we do the PRP first and then we do A2M. Okay, I'd like you in short to explain what A2M is. And then I want to ask you, do we absolutely have to do PRP before we do A2M? And does
Okay,
that
great question.
inflame my knee or somebody's knee?
Great question. Right. So A2M is alpha 2 macroglobulin. Alpha 2 macroglobulin is a protein that was discovered doing researching osteoarthritis that was found to be missing. So what it does is it shuts off the enzymes that lead to joint destruction. So let's go back to that inflammatory cascade again. So if you have some damage in your knee, there's going to be inflammation. One of those inflammatory molecules, while they do promote healing, they also degrade the joint. And so your body has a mechanism to turn that down. That's basically alpha 2 macroglobulin. And so by injecting alpha 2 macroglobulin into the joint, it basically slows down joint destruction. So it's
It's
been
good for
very hard
everybody,
for
right?
it's good for everybody, right?
It's
Exactly,
good.
because we're all if you're having joint pain, you have inflammatory cascade going on there, and you can minimize the joint destruction that results from that by using alpha two
So it
macroglobulin.
doesn't keep
So
like like looking like tissue paper, like it shows you on the MRI. You can stop that
exactly,
from
exactly, yeah, that
degenerating.
that exactly that inflammation is what's resulting in that loss of fine cartilage. So why is this not used more often? You're probably wondering. It's a great question. The reason is because it is more of an expensive procedure, and so a lot of clinics don't do it. I don't think a lot of people know about it too, for that matter. So
Yeah,
so you
I
have to
don't
buy a
either.
special. Yeah, it's not that's exactly it's not very common, and I think it should be more common. But you got to use a special filter, a special tube to draw it up, and it filters those larger macroglobulins, and it just captures that. So back to your question is, do you need to do the PRP first? No, the answer is no, because it's going to have regenerative potential in there. So, I mean, I think we like to treat everybody individually, and it depends what people are coming in with. If somebody has
Right.
moderate severe osteoarthritis, their joint is limited in mobility, they're not able to really play golf or play pickleball that they want to do, but they're not in a lot of pain, it would be appropriate to just go to that step because that's going to minimize the joint destruction, start the healing cascade, and then I would recommend more advanced healing procedures after that, more advanced regenerative procedures after that.
So I had another issue happen, which I didn't know about, but I found out with a cyst, or there's another name for it. What is it in your knee
Subchondral
that
cyst.
you don't know
Subchondral
about
cyst.
until you're injected? What is
Right,
it called?
right. Subchondral cyst. It's a product of the joint destruction and it causes a lot of pain. And you wouldn't know about it because generally speaking, you would do normal, you'd kind of do your protocol. You would treat the knee like it looks like. It looks like an arthritic knee. You would treat it like that. And if it doesn't get better, you would then do an MRI, and that's when you would find those cysts. You're not going to find it before that. So you got to
Just
kind of be
know.
looking for it. Yeah.
So, I want you to just touch on this for a second because everybody seems to be very confused. A lot of doctors consistently say, oh, you should do bone marrow or you should do autologous stem cells. Now, I've done both. Okay.
Hmm.
So I have my opinion, which is everybody's entitled to. And I'm going to voice my opinion. Then you can explain to people why. I am going to be 64 years old. I think I was 60 years old when I did bone marrow stem cells. They worked, but it took like 31 days before they actually let me stand up because I was wheelchair bound.
Mm.
It lasted for about 8 months until I started to degenerate again. And then I did exosomes, which actually got me up in 3 days. And then I also did the grafting of the fat for the other stem cells. And they were my stem cells. So my body reacted much, much better to the stem cells taken from my fat as opposed
Mhm.
to my bone marrow. Can you tell me why and what's the difference?
Between the bone marrow and the adipose-derived stem cells, sure. So stem cells can be derived from a couple places in your body, and the two most common places are the bone marrow and the fat. The fat stem cells, they're a little bit more plentiful, but I think the bottom line is when we get them from your adipose tissue, we process them down a little bit and we culture them, and that's gonna produce your own cells and that are healthy and viable and in sufficient numbers to help you out. Whereas if you do bone marrow, you skip that step. You just take the cells out of the bone marrow and then inject it down somewhere. So they're not as well processed. And
Right. But I
so
think
I
it's
think
more
that's
than
what
that because I think it's more than that because I think bone marrow stem cells deplete much more than what you would get from fat. Like if I'm 60 years old, my bone marrow stem cells are not as many, I want to say.
I
What do
have,
you
I have,
what do you think?
I have, yeah. I've come across research that says that adipose-derived stem cells are more plentiful in older
Yeah,
ages.
I believe
I'm
that.
not,
Plus you can
yeah.
plus you can bank them and if I need them in 5 years from now, and not that you can do so many other things with them, I think
Mhm.
that that's the best way to go as well.
Yeah, I think that's one of the strongest reasons to do adipose-derived stem cells because if you tissue bank them, and again, we tissue bank them, we test them for viability, and we culture them so there's sufficient numbers of them. So I think the bottom line, I was going to mention to you earlier, the bottom line is you can get cells from a lot of different sources, but really the key thing is, are they quality cells? Are these cells that are going to help you, or are they just simply cells that may or may not be alive? So
Right.
the advantage with the adipose-derived stem cells, the way we do it here, is we take them, we process them, we send them off to a lab. That lab looks at them and it takes the live ones and cultures them, and then it saves them. So they're tested, cultured, and viable.
Right. We can do both here, but I definitely think that the adipose stem cells are much, much better. My opinion.
It's a it, that's your opinion. Are you biased? Yeah, no, you've had them both,
A
so you
little.
you kind of
I, I,
yeah.
I only
So
go with what works for my body, and that
yeah, you're
works for my
entitled.
body, you
Good,
know?
good. Yeah, and I think the procedure to extract them is better tolerated than the bone
Definitely.
marrow. Bone marrow is really you kind of like got to drill into that bone, and it kind of goes all right, but then taking the cells out, that can be a pinch for some people.
Yeah, I
And either
agree.
way, we
Thank
do
you.
things slowly and carefully, and most people are okay. But the adipose-derived stem cells are better tolerated the extraction.
I agree. 100%, 1,000%.
Yeah,
And you
you
know
got them
what? You
both.
touched on something a little bit in the beginning when you said why people don't do certain procedures because they cost more money. Yes, I got to tell you, everything costs money. But if you're going to be in pain and you can avoid knee replacement, or you could be out of pain and you can walk again and go up and down steps and, enjoy your life, there isn't any amount of money I wouldn't give to do that. All the other things fall by the wayside. Those are priorities. Being
Exactly.
mobile.
It's too bad. Yeah, it's too bad it's not more common because we could avoid a lot of unnecessary surgeries. We could avoid a lot of unnecessary pain and debilitation and give people back the quality of life that they deserve. If we could do these
Absolutely.
procedures earlier.
100%.
So the best results are always early in the disease process, not later. And unfortunately, the way the system works is people have exhausted the normal healthcare system by the time they end up here. And by the
Right.
time
Or
they
they
end up
don't
here, we
know.
can
They're
still
not
help them.
educated enough. They don't know. That's why I'm so happy you're explaining everything, because most people go right away for PRP and they don't understand that some PRP, they may not take enough blood. They may not process it enough for it to even do anything. And some PRP can inflame you and not help you. So you really have to be looked at by the doctor and somebody who is a specialist in joints and injections, because not all doctors inject well. I've had good injections and I've had very bad injections, and those
Hmm.
keep you bedridden or in your chair. I've had
Right.
very good doctors referred to me that didn't inject me well, and I stayed
Hmm.
in a lot of pain.
Yeah. Yeah. And you had those had their consequences. I was going to mention that I think part of the difficulty in finding regenerative medicine earlier is there's a lot of misinformation and as you said, kind of ignorance about this stuff. So you can talk to a lot of doctors, and since it's not integrated into the normal healthcare system, they may not they may not recommend it with the sufficient weight. And so again, why is that? A little bit of it is ignorance. They don't see it, so they don't know, so they don't know what to say. But the other problem with it is a little bit more difficult to study this stuff. And as you mentioned, first of all, drug manufacturers cannot put a
I
patent on
can't
your
make
blood.
money off of it
They
because
can't
it's
put
your
make money
blood.
off exactly. Yeah, exactly. Nor your cells. And so
Right.
there's really not these big well financiers that are behind studying this stuff. And these studies thus done by people that are really kind of all over the place in terms of how they do it and in terms of the results they get and on all sorts of other things. And so it makes it harder to become adopted. So again, you want to go to somebody who's got a lot of tools. You mentioned we do the PRP, we do the exosomes, we do leukocyte-rich, leukocyte-poor, A2M, we do stem cells, we do a log autologous, we do autologous, and yeah, the other one. We do them all, and yeah, both of them, right? Yeah, so you really want someone with a lot of tools, a lot of experience that's going to inject under ultrasound guidance, and that's how you get the best results.
Yeah, and you're a great injector. So very
Oh,
happy to have
thanks.
you here at Rejuvenation and Bodygenics, and we'll be talking again.